of particular medications that are associated with treatment regimes. And we might also understand that there is regular review of medication in a person's care when receiving palliative care. Okay, so there might be a reduction in invasive procedures, regular access to assessments, and a focus on psychological and emotional forms of distress. We also understand that one of the things we can mark as a clear transition to palliative care is accessing advanced care planning. And advanced care planning will help the person to begin to think about the kinds of care that they might want at the end of their life. They might think about the types of care that they don't want at the end of their life. And they may also engage in active planning about where that care takes place. So again, it's a really clear marker of when somebody has made that transition to palliative form of care. The delivery of care is also a marker what we might take account of, particularly the integration of healthcare teams and the multidisciplinary team as a focus of that. An emphasis on family care and family support from healthcare providers, and also the use of complementary therapies, for instance, as another marker of a transition. But certainly, referral to palliative care services is perhaps the final and most easily recognisable marker of a transition. And that might mean, as I've already suggested, admission to a hospice, admission to a specialist palliative care service, or admission to a palliative care pathway. So these are the things we might begin to look for in the lives of people who are suffering from serious health-related conditions. And what we're talking about today is those examples or the evidence that we have suggests that some people, despite having palliative care needs, aren't making that transition to these kinds of services and these forms of care. So my first example is people with dementia. Now, we know that people with dementia suffer from a range of different symptoms, including memory loss, psychological and physical burden, as well as behavioral change and other mental health conditions such as depression. We also know that dementia is the umbrella term given to a whole range of different organic brain disorders that is more likely to impact people in their later life. And what I'd like to share with you is quite a complex table, but nonetheless one that was the result of a piece of work that was done in the UK some time ago that looked at the palliative care needs of two very large hospitals in the north of England. And what we attempted to do was conduct a census of all those patients in both hospitals during a fortnight, a 2-weekly period, and then begin to look at the kinds of palliative care services and forms of care that people were receiving. And you'll see that this is the result of a logistic regression form of analysis that highlighted the predictors of physical and psychological burden. And you'll see that those numbers that are in bold are indicating the conditions and the predictors of physical and psychological burden. And there are two that stand out, or there are three that stand out. Heart failure was a negative predictor, but the other two predictors that appear in this table are being female, but also a diagnosis of dementia. So we can see that the odds ratio of 3.94 suggests that the likelihood that you will be receiving, the likelihood that you will be experiencing forms of physical and psychological burden are very high in the cohort of people that we looked at. So that was demonstrating to us that people with dementia were by far the biggest group, and the group of people who were more likely to have palliative care needs. Now, despite this, we also looked at various indicators of palliative care provision, and we were able to see that 0 patients in this cohort had been referred to a palliative care service. 0 of this cohort of people with dementia had been admitted to a palliative care pathway, and zero of this cohort of people with dementia had an advanced care plan present in their medical notes. So that indicates to us that actually you've got this group of people who don't have cancer, they have dementia, but they have huge and very complex palliative care needs. And despite this, very few of them were accessing the kinds of care that we would expect to see should palliative care be available to all. And that's not the only piece of evidence that we have for this challenging barrier, if you like, to accessing palliative care for people with dementia. A number of studies, and I've just listed a few here, have highlighted a range of different aspects of care for people with dementia that can demonstrate again that people are not receiving palliative care. Sampson, who's done a huge amount of work around this field, has identified that in the US, less than 2% of the hospice population are people with dementia, despite the fact that the population of dementia, people with dementia in the population is very high in the US and in the UK. EIOPA have also identified the continued use of feeding tubes with no improved outcomes for people with dementia in the advanced stage. So that's where people are receiving quite aggressive forms of treatment, despite the fact that there is very little positive outcome for those patients as individuals and the population of people with dementia. And Davis et al. Also noted this. This is a more up-to-date piece of work that's been done to demonstrate that feeding tubes again have been used extensively with no improvement in quality of life or no improvement in the length of life also being evident. And Miranda et al. Has noted that in a huge survey that actually older people with dementia living in nursing home care provision also had palliative care needs without the provision of palliative care being provided for those people. So this is a challenge for people, and we'll begin to explore why that might be the case in a moment. But I'd like just to talk briefly about the example number 2, COPD and access to palliative care. We know that COPD is a hugely debilitating, serious health problem. We know that around about it accounts for around about 10% of deaths across the world, and many millions of people suffer from COPD as a result of industrial or behavioural aspects of their lives into later life. And again, we can identify a range of data that points to the idea that people with COPD don't access palliative care, certainly don't access palliative care to the same extent as people with cancer. So Rush et al. In 2017 conducted a large study in Sweden comparing the services that were accessed for people with cancer and those with COPD, and they were able to point to the huge inequalities, despite again the cohort of people with COPD demonstrating extensive palliative care needs. Ahmadi et al. Also undertook a study comparing the lives of people with COPD and people with cancer, and demonstrated actually that the treatment for breathlessness was far more prevalent in the population of people with cancer towards the end of life compared to people with COPD, but also that the needs of people with COPD in relation to breathlessness was much higher. Ajida, sorry, noted continued use of aggressive treatment interventions up until death for COPD, including multiple testing and assessment, despite the fact that this was having no impact on the length of life or indeed the quality of life that person was experiencing. And finally, Disler pointed to the fact that people with COPD were unable to access advanced care planning and have conversations about their future care, despite having very complex needs and the need to do that with a healthcare professional. And that brings me on to one of the key findings that I've been involved in for a few years, and that's that future care planning and advanced care planning for people with dementia and people with COPD are very limited. And that's largely down to attitudinal and cultural aspects of healthcare provision. Some work that has been done in the US by Lavelle and Yates noted that people with dementia and COPD were much less likely to access advanced care planning compared to other sections of the population, particularly people with cancer. The work that I've done with Jane McEwen points to some of the processes that are inherent within the care planning, advanced care planning framework, and have noted that there are huge challenges for people in relation to accessing information, accessing somebody who will build a relationship with that person, that family, to undertake care planning. And we've noted also that the skills within the workforce are not sufficient to deliver advanced care planning opportunities for people and to build those relationships. And two studies that are related to COPD suggest that the episodic nature of COPD in relation to hospital care, and also in relation to the lack of a relationship that people may have with a trusted healthcare professional, means that they are unable to access advanced care planning opportunities, and therefore are denied this as a potential route to determine their future care. And we know that advanced care planning is very important in relation to palliative care, because many systematic reviews have identified that if somebody has an advanced care plan in place, then they're less likely to be hospitalized at the end of life. They're more likely to die in the place that they choose to die in. And they're also more likely to have those medical interventions that they do not wish to have not present within the final months of their life. So these, again, are things that lead us to understand that people with dementia and people with COPD, despite having extensive palliative care needs, may be at risk of experiencing the kinds of treatment that are inconsistent with that kind of approach.
Sure, we pay for it better.
So there are three explanations I'm going to kind of briefly touch upon as to why this is the case. And the first of those is something that we've called candidacy. And what that means is that when people are making decisions about referrals to palliative care services, particularly at a community level or indeed in a hospital, such as a referral to a specialist palliative care service, we know that people are less likely to see people with dementia in particular as candidates for those kinds of services, and much less likely than they are to see people with cancer as candidates for those kinds of services. So this is quite remarkable, not remarkable, but certainly I found quite shocking data when we went to interview healthcare professionals about the likelihood that people with dementia might access palliative care. And you'll see that this first quote says, you know, I would think in terms of beds, we're struggling as it is for palliative care cancer. And if they take people with dementia, it's going to be absolutely chaotic. So what we have here is a general practitioner, medic, talking about rationing hospice services in favor of people with cancer to the exclusion of people with dementia. We also have in the other two quotes on this slide, a lack of understanding about the fact that people with dementia will experience extensive palliative care needs. And in fact, the final quote, dementia is not terminal, is completely wrong. We know that dementia is a terminal illness, and in fact, dementia is now the leading cause of death within the UK. So all of this data would suggest that people who are making decisions about palliative care referral don't understand the needs of people with dementia, and therefore this whole idea of candidacy becomes very important. The second potential barrier that I'm going to talk about today is the organisation and healthcare delivery. And this is where there's a focus on episodic nature of hospital care. So people may experience in their care trajectory a lack of continuity with people, with individuals who can help them to make the right decisions. There's a great book by Catherine Froggatt and Myrna Downs, both UK dementia researchers, who talk about life worlds and system worlds. And what this means is that in the lives of people with dementia, there is this huge, complex, relational and social world that we all know. But when we enter a hospital, we get put into a system, and that system denies choice and denies us the opportunities to have the things that we want. And they've applied this whole idea of life worlds and system worlds to the experience of later life and advanced dementia, and have identified it as a potential cause for the fact that people with dementia don't access palliative forms of provision. Also, I don't know if anyone has read Susan Kaufman's book on end-of-life care in hospitals, but also she points to this notion that actually there is a denial sometimes of death in hospitals, and people, in particular medical staff, may be less likely to help people make the transition to palliative care because they would rather work hard to sustain life rather than provide people with a dignified quality death. And finally, there are also big issues, and I think this is possibly a big issue in Indonesia, around the reimbursement for some conditions of palliative care, and in particular COPD often is one of those conditions where reimbursement for palliative care is not available, and so that's a technical, organizational funding issue and a policy issue that is preventing people to make that transition. Final barrier that I'm going to touch upon, although there is much more to this, but I've chosen three just to kind of fit within the time really. But the final barrier is that of prognostication. We can see this figure on the left here, which you may well be familiar with, is a figure that has become synonymous with recognizing the kinds of trajectories, disease trajectories that people experience towards the end of their lives. And we can see that the blue line is related to cancer, which is, I wouldn't say very predictable, but it's certainly very clear at which point somebody is beginning to reach the final weeks and months of their life. And therefore, prognostication about these events is quite straightforward and less messy, if you like, there compared to other conditions. Whereas we can see that the dotted red line is related to diseases such as organ failure, but also COPD is a little bit like this. And that's where decline takes place over a longer period of time. There are periods when somebody is relatively well, but also periods when somebody is not so well. And so the trajectory is complex, it's messy, and it's also unpredictable at times. And similarly, the green line on the bottom there is the trajectory which is related to frailty and dementia. And again, we can see function over time is sometimes improves, but other times it's not. And the process towards those last few weeks and days of life is very protracted. And this leads to big problems with prognostication. Medical and nursing staff and other healthcare professionals find it very difficult to determine when somebody with dementia or with COPD is beginning to reach the final stages of their disease. So there is evidence, for instance, from Mo et al., suggests that people with dementia suffer from this challenge that healthcare providers have. There is also a reluctance for some people within the kind of dementia care pathways to refer to hospice care because they might see that as not justifiable at times, and there's also stigma attached to moving into hospice situations. And this final piece of work done by Vermeulen suggests that there's difficulty in prognostication for COPD because people and doctors and medics and other healthcare staff may struggle to recognize the terminal phase of the illness. So there are very good reasons, therefore, in this case, for and highly technical reasons for maybe for one of the barriers to palliative care being prominent within the literature. Okay. So the third example that I'm going to talk about relates to the visit that I made with some colleagues from Banda Aceh a few years ago, and some field work that we did there around accessing palliative care for the local population. This is just a general slide to introduce us to this topic, suggesting that out of the 50 million people who don't access palliative care, a large proportion of those people live in low to middle income countries, and we'll recognise from this figure here on the slide, the map, where we can see that some countries are quite bloated, where that's indicative of a high degree of access to palliative care, whereas some countries that are physically in terms of the world map, quite large, but on this map, they're very small because people aren't accessing palliative care in those countries. And there's a whole number of reasons given for that, particularly around, also evidence given for that, particularly around the consumption of morphine and other opioids is vastly disproportionate in high income countries. We also know that 60% of the world's population live in countries where there is very limited provision of palliative care, which is another potential source of evidence for us around this. There's a shortage of appropriate facilities, and also palliative care training and education may not be as extensive as high-income countries as it is in low to middle-income countries. And we decided to pay a visit to a lovely part of the world that I'm sure lots of you know. You're in part of your beautiful country, Banda Aceh, is a long way from where you are, but may have particular. I don't know what's happening there on the screen. Similar kinds of infrastructure in relation to palliative care. This was a piece of work that we did which involved some focus groups and interviews with healthcare providers across the region, and also some academics that were involved in the study. We did this study in collaboration with Sia Kuala University in Banda, and I'm just going to raise three prominent themes that came from that work. The first is related to funding and national policies, and I'm sure this is a topic that's familiar to you, but we were able to. This is a picture of the hospital in Banda, where we conducted a lot of our work, but we were able to see that the government policies around insurance, for instance, restricted access to palliative care and restricted the coding and labelling of forms of care as palliative. So this top quote here says that hospice care and home care visits, we can do that in a cost-effective way, but again, the government don't see this. So that's a real tension between what healthcare practitioners were able to see as the palliative care needs of their population was at odds with government policy around the insurance payments that could be received for that. And one way around this was for hospital and community staff to undertake palliative care, but label it as something else. In particular, psychological services were labelled. Palliative care was labelled as psychological services on occasions, and that was to meet the needs of the population, but also to be reimbursed for that particular provision. And there was a real kind of dilemma for people that we spoke to, and saying that that the government wants cost-effective care, but still pursue this idea of giving very aggressive forms of care in ICU, for instance, for people with palliative care needs, where that was both inappropriate, unfeasible, but also very costly. And so the healthcare professionals that we spoke to were adamant that they could change things if only the insurance system would change in line with the way in which they thought that care could be delivered. There were also huge problems around community access, and the kinds of cultural challenges that were being faced. So this top quote refers to a family that actually recognized that they didn't want the person that they cared for to go into a hospital because they had experienced before or knew of people's experiences that were related again to these kind of aggressive forms of care, and admission to hospital wasn't something that they wanted to do, and that was the only option for them. So there was no other community forms of palliative care provision to meet that need. There are also clear challenges around the use of opioids and access to opioids for people. But this final quote relates to the kind of rural geography, if you like, of the region, where people with cancer would need to travel for many miles from some of the islands that were far away to access hospital care just for a small amount of opioids to relieve their pain. So there were issues here about the experiences that people had of hospital care, about the access to opioids, but also the geography of the region meant that things were very difficult for people in accessing palliative forms of care, and therefore the transition to those kinds of services was restricted. But there was some hope, and I think that one of the things that appears to me, I think the people here will be in a better position than I to talk about this, but it seems that palliative care is emerging in Indonesia, but in isolation and in pockets in different parts of the country, and mainly in cities. And in Banda, we came across some real sort of local leadership and local drive to build palliative care. And so people talked about individuals who had an innovative approach to palliative care, wanting to build services and build palliative care units. And I believe that since we carried out this field work, that leadership has borne some fruit, and there is indeed a new palliative care unit in the hospital in Banda, which is fantastic for people. That's come out of local leadership, as opposed to a national system of palliative care. And so both of those bits of data there begin to describe why it is that and how it is that palliative care change can come about in a place where previously it was very restricted and didn't fully exist. So as well as kind of local leadership, that brings me on to my sort of final slide, which is where we begin to identify opportunities for improved transitions in the future. And we're beginning to see now in Europe, for instance, very clear policy directives aimed at establishing palliative care provision for people with dementia and people with COPD. So both of those conditions are being recognised in continent-wide pan-European networks and guidelines and protocols that have been driven around the development of palliative care for those groups of people. We're also beginning to see practice-based evidence in relation to improved transition in both COPD and dementia. So there's a number of trials ongoing at the moment that are beginning to demonstrate how it is that that we can begin to design new pathways for people with both of those conditions, whereby they may be able to access appropriate palliative care that suits their palliative needs across the disease trajectory. And finally, we're also beginning to see educational interventions, again, for both of those groups, that are preparing our workforce for the tailoring of particular forms of palliative care that address those needs, and in a sense, building capacity within the healthcare workforce to help us to do that. Okay, that's the end of my talk. I've got lots of references on here, but I believe we've got some time for questions.
Okay, thank you very much, Tony, for a very interesting presentation. It's very important issue that you brought to us. So I would like to give a little bit summary in Bahasa Indonesia to make a little bit connection with the audience. Oke, so Ibu Bapak semuanya, Profesor Tony Ryan tadi sudah menyampaikan beberapa aspek yang penting terkait dengan transition care ya, terutama dalam konteks perawatan paliatif yang dikhususkan pada populasi lansia. Ada dua populasi besar penyakit yang pada prinsipnya kurang mendapatkan perhatian yang spesifik terkait dengan perawatan paliatif, yaitu PPOK dan juga demensia dalam hal ini. Dan tadi Prof. Tony juga sudah meng-highlight beberapa isu terkait dengan hambatan dan tantangan kenapa perawatan paliatif itu pada dua populasi ini masih di bawah prioritas ya. Jadi terutama di negara-negara di lower middle income countries ya. Jadi di beberapa barrier tersebut diantaranya adalah memang keterbatasan dari akses, kemudian ketersediaan dari sumber daya yang memang kompeten dalam perawatan paliatif, kemudian juga keterbatasan dari penyediaan opioid sebagai pain management ya, painkiller, kemudian juga aspek terkait dengan hambatan geografis yang juga menjadi kendala utama bagi orang-orang yang memang membutuhkan perawatan paliatif. Kemudian juga Prof. Tony juga meng-highlight aspek terkait dengan penyediaan pendanaan, pembiayaan kesehatan yang juga memang terutama di negara-negara berkembang itu belum mendapatkan prioritas. Dan satu lagi juga yang tak kalah penting adalah dalam aspek leadership, di mana leadership ini menjadi salah satu daya ungkit yang bisa membuat untuk meningkatkan ketersediaan pelayanan perawatan paliatif itu lebih maksimal. Nah, mungkin itu yang sekilas tentang summary dari konten yang disampaikan oleh Prof. Tony. Okay, so ladies and gentlemen, now we open for question and answer. For anyone who want to share the thought or question, can raise your hand, and you can on mic and on cam, or you can drop a chat in the chat room. Okay, is there any? Okay, while waiting, Tony, so I highlight the important issues about the advanced care planning. I think this topic, especially in Indonesia, it's really rare to be discussed. Focusedly on end of life care. I try to connect with your study with your colleague in Banda Aceh, and I think it's also happened in other place in other part of Indonesia. So maybe you can give some more explanation how advanced care planning for elderly people practice in the UK. So maybe you can give some more thought about this. Thank you.
Advanced care planning in the UK has been available to the population for a long time, and it takes a number of different forms, some of which are legal kind of documents that when a person states that they do not want a particular form of care at the end of their life, then the practitioners have to respect that. But there are other forms of advanced care planning that are a little bit less formal. So it has been available to people for a long time, but also in the UK there are huge proportions of the population that do not use it. So it's not just people with dementia and people with COPD. However, people with cancer are more likely to use advanced care planning, and the almost like the organization of healthcare provides the opportunities to a greater extent. I think the US use of advanced care planning is much more widespread, and there's lots of evidence to say that that people are more likely to record their wishes and plans for the end of their life in the US than other parts, and Canada, I think, as well, and other parts of the world. But nonetheless, it is a powerful tool, a powerful mechanism, and as I said, Brinkman's de Pollenberg, I think the name is, have identified through systematic reviews that if you have an advanced care plan, you're much more likely to die at home or die in a place of your own choice. You're less likely to receive the kinds of treatment that might be associated with those aggressive interventions at the end of your life. And you're much more likely to experience in respect to your choices to be respected towards the end of your life as well. So it is a powerful tool. It has been available in the UK for a long time, but we're very reluctant to use it for some reason. But again, the work that we did with people with dementia was interesting because we recognized actually that this is rather than a one-off episode, it's actually a process that people go through. And I think that the opportunities to discuss with a healthcare professional one's advanced care plan, you're given one appointment with a psychiatrist and a psychiatric nurse after your diagnosis, one appointment, and that doesn't give you enough time really to talk about these things. Rather, what happens is that people go away from that appointment and begin to think about the future over a long period of time, and yet are not given another follow-up appointment to go and talk about these things. There were some of the issues that we came across.
Okay, thank you. Okay, we're still waiting. Actually, we have some doctoral students, PhD student here who already undertake a palliative care as become their thesis project. Maybe is there anyone to ask to Professor Tony Ryan for the PhD student here? Okay, so while waiting, I also continue to highlight about the. Okay, we have one question. Maybe Ibu from Atlastika. So Ibu Asti, would you like to ask by yourself? You can on mic and on cam. Okay, maybe she has another things. So okay, I would like to read her question to you. So dear Professor Ryan, I would like to ask a question. How important are disease trajectories in addressing patient and family expectation? Thank you.
Well, as we know from that well-known figure that I presented, we can see that disease trajectories are very different for different disease conditions, and therefore, and also for individuals. They are models. They don't prescribe how somebody's going to experience their condition. But you can see that in the case of a condition like dementia or COPD, the expectations that somebody might have are unknown and certainly variable over time. The length of time is very difficult to define, that someone might be experiencing their condition before they die. The rate at which change occurs for somebody is also unpredictable. So therefore, expectations, I think that's a really helpful question, because expectations are also hugely challenging to begin to understand, and certainly therefore it presents the families with some uncertainty for the person that they're caring for, but also for themselves.
Okay, so Ibu Asti, are you satisfied with the answer? Do you have another question to Professor Tony about this? Okay, she said that she has very unstable internet connection, so it's very clear. Thank you. Okay, so yeah, while waiting another, if the audience had another question, please feel free to raise your mic, or you can write on the chat room. Okay. Oh, we have Dr. Maria Wicaksono. Yes, please, Dr. Maria. Maybe you can on mic and on cam. So, Professor Tony, I would like to introduce one of the participants, Dr. Maria Wicaksono. He is a very important person in Indonesia who introduced about palliative care, the important palliative care in Indonesia. Please, Dr. Maria.
Thank you so much, Ibu Hana, and thank you, Professor Ryan, for your interesting lecture this afternoon. Yes, I agree with you that prognostication in COPD is much more difficult compared to cancer patients. My question is, in your country, when do you initiate palliative care for this type of diseases?
Okay, Maria, that's a
Maria.
really great question. I think it's variable, but we do know from the evidence that actually people with COPD might be experiencing care that is aimed at curative care rather for much longer than really should be the case. And so we know that people are experiencing quite aggressive testing and assessments up until the end of their life. And there's some data I think available to suggest that even within the last 2 days of life, people with COPD are still experiencing curative forms of care and treatment. So it is a big problem, I think, that people, not all people, but a lot of people with COPD are experiencing and not gaining access to those forms of palliative care that we might expect. That said, it's transition to palliative care is a difficult thing to measure, as I tried to kind of say at the start of the lecture. We can count certain things and we can measure particular referrals and movements between different care environments, but we can't recognize the love and care that's given within families that is also really important palliative care. So my answer is that I don't think early enough, and people certainly continue to receive those forms of care that are potentially not appropriate, and those palliative aspects of their experience are often delayed.
Okay, thank you so much. Another question is there any screening tools that you use in for this kind of disease? And how is, if the not the patient, but the families has problem, like they have social problems or financial problems, instead of, referring to the palliative care due to patient's problem, but the family's problem? Is it possible?
Yeah, absolutely. Well, certainly, I think, in relation to COPD in particular, we know that COPD is related to particular health behaviors and particular in work experiences, particularly in heavy industry. In this region, in the coal industry, for instance, the coal mining industry is linked with COPD. And so therefore we know that those families are more likely to be experiencing the kinds of things that you've just described, such as access to goods and services, access to benefits. They certainly are people who live in the poorest housing within our region. So I think absolutely, Maria, you're correct in observing that as well as caring for the people within their families, they're also having these multiple experiences that challenge them in different ways, and also present them with huge problems that they also have to overcome at the same time as caregiving. So yeah, absolutely, I think that and COPD is of course one of those conditions that tends to be associated with people in low socioeconomic positions.
Okay, thank you so much. Thank you, Ibu Hana.
Thank you, Dr. Maria. Yeah, so I think we still have 2 minutes left, Tony, for the remaining time. So is there anyone to ask one question only? Just one short question only. Is there anyone to want to ask? Okay. while waiting, I have one question actually. It's quite curious about the culture of dying and death, Tony. So
Mhm.
from my PhD study, I interview the nurse who work in intensive care unit and emergency unit, and they say that caring for the end of life is very important. However, they feel afraid to make a care, and then they don't know how to provide the best care for people who are dying, and some of them, they are afraid of dying and death itself. So can you suggest something for our nursing students? Because here we have nursing students, we also have practitioner nurse, and we have nurse educator. How to deal with that kind of situation?
Well, it's also a challenge I think that we're facing in the UK. There's a culture around death and dying, particularly in healthcare environments. That's almost failing to recognise when death is coming. So in our data that we have for the transitions project that I talked about, the census that took place in 2 large hospitals, we also surveyed nursing staff and medical staff. And nursing staff actually were much more likely to be open about the potential for death for the patients that they work with compared to medical staff. But still, it is a huge problem, and we've been doing some, not me personally, but a colleague of mine, Fiona Wilson, has been running what is called death cafes for the nursing staff in our university, where people begin to talk about death and people begin to be open about it, to help nursing students in particular to reduce the stigma of death in their work. So that's one very small idea that I think works very well. But I think building capacity and capability within the nursing workforce is our responsibility to some extent. Working in nursing departments, to help to prepare people for to talk about death and to be open about death before they can even begin to understand those skills that might be associated with highly capable palliative care practitioners.
Thank you. I highlight that cafe. So maybe we can try to use that cafe in our faculty. I think maybe
Absolutely. Well, Yushi, we can talk to Yushi about putting her in touch with Fiona Wilson, who will talk to you about death cafes.
yeah,
I'm
very
sure she'll be
interesting.
very happy to. Yeah,
Yes,
yeah.
please, yes, for sure. I think we need to continue for another lecture series specific talking about that cafe, because I think
Yeah,
many
absolutely.
people are curious about this. Okay. So anyway, Tony, thank you very much indeed for a very impressive and very interesting presentation, because time is up. So for ladies and gentlemen, I think the most important thing here to summarize this, the most important thing, how to increase our competence to provide the palliative end of life care. So, and providing a good and structured education is a must, I think. So, I think by giving a good education should not wait until we have a very established palliative care in Indonesia. So we can do in parallel, I think. So thank you again, Tony. Time's up. So
Thank you, Hannah.
yeah, I return to the Master of Ceremony. So please wait for a while, because we have the appreciation for you. Please to MC, Bram, and Ajang. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Well, I would like to thanks to Mrs. Hannah for being the moderator of this hybrid lecture series. And I also extend my thanks to Prof. Tony Ryan from the School of Allied Health Profession, Nursing and Whitebury University of Sheffield, United Kingdom. And next we have a gift for Mrs. Hannah and for Professor Ryan. And this is a gift from us in the form of a certificate as a moderator and speakers of this hybrid lecture series. Once again, thank you so much for today's session for this lecture hybrid. Okay, so this is a gift for Mrs. Hannah Rismadewi, Agustina SKP, MN, PhD RN in the form of a certificate as a moderator of this hybrid lecture series.
Thank you very much.
Much.
Spotlight tuh.
Oke.
Oke, boleh spotlight kita. Oke, baik. Tadi itu kita sudah mengikuti acara kegiatan hybrid learning pada pagi hari ini dengan kedatangan speaker kita ya Teh ya, dari jauh yaitu Prof. Tony, yaitu
Ryan,
Prof.
yes.
Tony Ryan dari United Kingdom.
Betul
Wah,
sekali, Kak.
ternyata kegiatan hari ini sangat mengasihkan sekali dan juga berkesan sekali ya Teh ya. Oke, mungkin kita akan mengingatkan kembali kepada seluruh peserta yang sudah hadir pada hari ini. Boleh mangga untuk mengisi link absensi yang sudah tertera yang ada di chat Zoom ini, maka kami persilakan untuk mengisi absensi tersebut.
Baik, Kang. Jadi karena sambil menunggu para
Hmm,
peserta untuk mengisi absen di Google Form,
betul.
tak terasa kami juga sudah di penghujung acara,
Hmm.
dan sebelumnya kami ingin mengucapkan terima kasih dan apresiasi sebesar-besarnya kepada para peserta yang telah hadir pada sore hari ini dan juga aktif pada kegiatan hari ini.
Betul banget. Untuk itu kami mohon maaf apabila ada kesalahan kata ataupun kekurangan dari perbuatan dari kami.
Betul, selain itu kami juga ingin mengucapkan terima kasih kepada Akang Teteh Panitia yang sudah membantu kelacaran pada kegiatan hari ini, dan tentunya akan ada hybrid lecture series lainnya yang
Betul
perlu ditunggu.
banget. Jadi
Betul.
jangan lewatkan untuk hybrid learning series berikutnya.
Betul
Semoga
sekali.
dari hybrid learning series ini kita dapat banyak sekali manfaat yang kita dapat diambil tentunya di pada hari ini juga.
Iya, betul.
Sebelum itu, saya Bram
Dan saya Ajeng Lestari,
selaku Master of Ceremony Hybrid Learning Series Spectrum, Supportive, Palliative, and End of Life Care Transformation Forum. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you everyone. Thank you Bram Ajeng. Thank you Tony. Thank you Yusi and everyone. So I'll see you again with talking about Date Cafe. Okay. Have a good
Terima
rest.
kasih.
Have a good day, Tony, for you. Bye.
Oke, terima kasih semuanya ya.
Oke. Terima kasih semuanya. Sampai ketemu lagi di series berikutnya. Izin live.